Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I want to talk about the Adductor Magnus. It's an interesting muscle. The key facts about the Adductor Magnus that I wanted to mention were that there is a front portion and a posterior portion, that there's a pubic attachment, and then there's an attachment at the ischial tuberosity, and there's two different innervations. The front portion is innervated by the obturator nerve, and then the posterior portion is innervated by the sciatic nerve. Some people call the posterior portion of the Adductor Magnus the fourth hamstring, and it is innervated by the same nerves as the hamstring, and the direction of the fibers is fairly vertical, like the hamstrings, whereas the front portion has two separate directions of fibers. There's a very upper or proximal section that is more horizontal, and then the biggest part of the front portion of the Adductor Magnus is at an oblique angle, going all the way down to just above the knee. So the upper part that is more horizontal, like a pectineus angle, attaches to the medial portion of the gluteal tuberosity, where the lower parts of the glutes attach. And then the rest of that front portion that has an oblique angle attaches to the linea aspera in the back. And then there's a supracondylar connection right above the condyle of the femur, the medial condyle. And then there's a little adductor tubercle. But the main point here is that, like all the adductors, it helps pelvic stabilization when walking, which basically just says, keeps your hips from dipping down when you're walking. Your adductors and your abductors, like the gluteus medius, gluteus minimus, and the TFL, they work together to keep your pelvis in alignment when you're walking. So the adductors are very important pelvic stabilizers when you're standing or running. Now, what's interesting, though, is that the posterior part acts more like a hamstring, which I wanted to mention because if you're working with athletes and they're really looking for power, they're looking for explosive strength coming out of a squat. So that could be somebody, it could be a skater or hockey player, it could be a football player, it could be a power lifter who needs to get up out of the hole when they're down in a deep squat. That movement, when the hip is flexed and the glutes are stretched and the hamstrings are stretched, the Adductor Magnus is really the strong muscle, the strong hip extensor that's going to get you up out of the hole. So making sure that someone's Adductor Magnus, especially that posterior segment, is functioning and firing properly, it gives them a lot more explosive power. And it's a muscle that's prone to shortening, which would make it weak. So for athletes, really pay attention to the Adductor Magnus when you're suspecting something with a hamstring. Very often Adductor Magnus is also involved, or you'll think that it's a high hamstring issue when it's really actually an adductor magnus issue, because they really are very similar in that area. The front part of the adductor magnus can help hip flexion. So the posterior part can help with hip extension, especially with the hips flexed, and the front part helps with hip flexion. So they both heads will adduct, but the front part can help hip flexion. So for runners, you'll find that the front part of the adductor magnus can get tight and short, and then that can lead to all sorts of things like a knee valgus situation or valgus strain that starts to cause medial knee pain. If the gracilis is involved, there may also be like a pes anserine issue. So really the front portion of the adductors are to be considered for things regarding adduction and hip flexion. Interesting notes about trigger points in the adductors. You'll see sort of a high hamstring strain, pain on the ischial tuberosity, pain on sitting, pain on explosive movements like jumping or sprinting. It can be the hamstrings, of course, but that adductor magnus is very often involved, especially if someone's injured themselves doing something explosive like hill sprints, anything where the hips are flexed. Think of cyclists, competitive cycling. Like you're bent forward, the hips are really flexed. A lot of that strength is coming from the adductor magnus. It's not all glutes and hamstring. So really for that pain on the ischial tuberosity, you got to check the hamstrings and that posterior ischiocondyle condylar connection from the back of the adductor magnus. If you're familiar with the trigger point handbook from Travell and Simons, you'll know that there's some really unusual pain referrals from the adductor magnus that you don't see in a lot of muscles. That can be rectal pain, vaginal pain, testicular pain, a lot of internal pelvic pain. So when you have a patient who's been cleared by doctors of anything nefarious and they're still having this pain, you really want to search for trigger points in the upper part of the adductor magnus. And in my experience, it can be either the posterior or the anterior part. I think most of the genital pain, except for the testicular pain, is usually from the posterior part that goes to the ischial tuberosity. I feel like that anterior part is the one that I've seen causing testicular pain. I remember treating a powerlifter, competitive powerlifter, who he felt the adductor strain on a squat and then immediately had testicular pain on that side. And he texted me and said, "I think I hurt myself, and I'm getting pain in my." He didn't say testicles, but his testicle. And sure enough, treatment with trigger point release of the adductor resolved the pain, testicular and the adductor strain. I think that the posterior part is more likely to cause rectal pain, vaginal pain, pelvic pain, pain during sex, especially for women. It'll feel like internal pelvic pain when there's trigger points in that upper proximal part of the posterior segment of the adductor magnus. Trying to think if there's something else I wanted to mention there. Adductor magnus is just really, really important, and it's easy to overlook adductors. It's easy to get focused on just the abductors, the glutes, TFL, hip flexors, and quads. But adductors are very, very important, and they are prone to shortening. So short, tight adductors inhibit your abduction. So that's going to inhibit your glute medius. your glute min is going to get tight, fighting against tight adductors. And adductors can put your knee into a valgus strain. If you see somebody doing a squat and their knees are collapsing in, it could be more than just weak abduction. It's very likely short adductors. So you really want to pay attention to that, and you have to palpate your patients with proper communication, so they know exactly what you're going to do and why. There is no reason you can't palpate the upper proximal segment of the adductor magnus and just explain that this is why we're doing it. And believe me, when people are living with that kind of pain, pelvic pain, they're not shy about somebody working on them, especially when you're probably the first person who ever discovered the source of their problem. So I won't go into the needling techniques for that, but just know that mostly you're going to be grasping the needle, grasping the muscle, and to pull it away from the body. You need to learn in person. I really feel like it's important to know exactly where you are and have somebody confirm it. Somebody who's done it hundreds of times can point at where you want to go and what direction you want to needle, because there are nerves, arteries, and veins in that medial thigh area. That said, you can sometimes see femoral nerve impingement, tingling, because of the adductors being tight. So there's this adductor canal that the nerve comes through, and I think it actually can impinge the vascular blood flow there as well. But of course, that's something that a doctor really needs to be working on. But if you have somebody who gets tingling down the medial portion of their thigh, it can very well be femoral irritation by that tight adductors pushing on the adductor canal. So I guess that is everything. Oh no, I want to mention one other case. I had a high school athlete who had strained his hamstring, and he had been through physical therapy, and his mother was really just, frustrated that he wasn't getting better. He could still run, but when during the game and after the game, he'd have a lot of hamstring pain, upper hamstring pain and pulling. It was just uncomfortable for him. So when I first saw him, I tested his hamstring length by lying him on his back and lifting his ankle up, passive range of motion, just to see if we got to 90 degrees. On the good side, I didn't get to 90 degrees. It was more like 70 or maybe 80, but not 90. And on the injured side, it was even worse. I treated his hamstrings, and just I just want to explain why I think I missed the adductor issue on the first visit. Because his mother had already told me it was a hamstring strain, and that they'd been through physical therapy for it. So I was pretty much just trusting that, because I'm not that skeptical, not that cynical that I'm going to say, oh, they got it wrong. So I was treating the hamstrings for him, and he felt better in the treatment room. We got a little bit better passive range of motion on that hamstring after the treatment. So I thought, okay, he'll probably be fine. And teenagers, they bounce back so fast. You just release the muscles, they go away, and they're great. Well, he wasn't great. His mother reached out a few days later to say he's still having pain when he runs. I said, okay, come in. I fit them in, and I told her, I'm not going to charge you. I think I want to see what's going on here. I think I missed something. So when he came in, I decided, okay, throw out the diagnosis and just consider everything that could be involved here, and really think it through as if nobody had told me it was a hamstring injury. And I decided, look at Adductor Magnus, because it's that fourth hamstring. I said, listen, I know this is not what you were told, but I need to confirmed that there's an adductor magnus issue, and I asked the um, the 16-year-old athlete if he ever had any pain on the back inner part of his thigh, and he did. And I said, "Do you mind if I just push? I just want to push on this muscle, and you tell me if it's tender or painful." So I pushed on the adductor magnus from the inner part of his thigh in the like middle range, and he said, "Yes, it's really sore there." I said, "Okay, I'm going to push on the other side. I want you to just tell me if it's the same." He said, "No, there's no pain on the other side at all." I said, "Okay, so this is what I want to do. I want to treat as if this is an adductor issue more than just a hamstring issue." Okay, and long story short, I treated the adductor. His leg went so far beyond 90 degrees of hip flexion when I did the hamstring length test again. It was unbelievable. So of course I treated the other side just to get him back to even. But then his mother was both excited and angry. She was excited that he felt better and that he um, was clearly happy that he felt better. But then she was kind of frustrated. She said, "How could they have missed this? Like, how did they not see that? How has this not been part of the diagnosis?" And I just said, I don't really, I can't say like what they were thinking. There probably was a high hamstring injury, and they were rehabbing that. And I think along the way, they just didn't assume that there would be anything beyond the hamstring injury, and there was. And his adductor Magnus may have gotten tight as a compensation for the hamstring injury. So I would say, it's no one to blame. I just think it was a little more complicated than your usual hamstring injury. And, hopefully he's going to feel much better. And if he's not, then come see me. And I'm not going to charge you for this visit because I feel like I missed something. And I shouldn't have just gone along with the initial diagnosis. I really should have um, decided to test out other theories. Part of my problem there was that when I'm working with teenage athletes, I like to use as few needles as possible. So I feel like I feel for them. I can't imagine getting acupuncture as a teenager. I don't know if I could have done it. Um, and I just try to use very few needles. So for him, it was really, I think I used 4 needles for his hamstrings with him with one just for one leg because it was his first acupuncture visit ever, and I'm using electric stimulation. So that's my explanation. It's not an excuse. I feel like I could have done better that first visit, and had he been a 20-year-old athlete, I would have probably gone through a lot more manual muscle testing and just thrown out what the PT said. I'd have, but like I said, for teenage athletes, I really like to just do few needles, very short amount of time for electric stim, just so that they're not freaking out. Um, but there you have it. It was more of an adductor magnus issue at the end that was keeping him in pain, and I can't say that he didn't. It wasn't that he had an hamstring injury. I believe he did. It was healed, but the adductor magnus was just overworking to compensate. So that's it for today. I hope I said something that was of interest to you. Follow me on Instagram, Rich Hazel, or if you ever want to email me, please email rich@richhazel.com. I enjoy hearing your case studies and what you're getting from this podcast. And that's it. I hope you have a great week.